Back with another PCBH Corner. I'm joined by Dr. Bauman, and we have a fantastic topic. Although I feel like we always say that.
Well, I would also say that they are fantastic topics.
And these topics, most of the time, are born out of questions that we receive from folks in clinic, as well as other clinics who reach out. And so we get to the point where 3, 4, 5 times, you kind of have the same questions being asked, and we think we should shoot a corner. So,
which is a plug for people watching the corners, that if you do have regular questions that come up, reach out for us, because they really do turn into PCBH Corner. So we really do appreciate people reaching out, giving us questions.
Absolutely.
Yeah, my mind said really 5 times there. Let's get into it.
So, myths of PCBH is the topic. And myths from the perspective of maybe even misconceptions, myths, urban legends, if we want to say that. And that's from the perspective of not only mental health providers, behavioral health providers, physicians, medical providers, administrators, patients even. I know that's very broad, but time and time again, I feel that I'm correcting misconceptions all of the time about the work that we do. So, I want to pose to you, what are some of the top misconceptions that you hear about what primary care behavioral health is?
My mind literally explodes, and I wrote some of these things down, and let's maybe try to, even as we're going through, write down other ones, because I think one topic will lead to another and another and another and so forth. What's interesting is that I think the biggest myth that I always run into is, well, the 2 biggest myths, I would say, is that PCBH is for mild to moderate concerns, and then PCBH is not relationship based. It's more just brief therapy. I would say those are the 2 biggest myths, I think, that really dominate what people think, or as you said, misconceptions, whatever it might be. Those are the 2 larger ones I feel always come up.
And these are very similar to yours, the triage and refer model.
Right.
Which I guess would be
which go along with that.
Related, but slightly different, because with mild to moderate, and then I guess it would be refer anything that's severe.
Yeah.
I guess, and then not being relationship based or relationally based. Excuse me, and then the triage and refer.
And I think it's important for us, we dive into these misconceptions, these myths of it. I also think it's good for us to talk about why it is so important for us to bring this to the forefront about the myths, because they have really, really difficult ripples.
Yes.
When they're held by patients, by BHCs, by medical providers, by administrators. It really does ripple out into all these different people in just not productive and functional ways.
Yeah. So walk me through that. Which one is it? The 1 to 4 visits, which I guess
might be the brief part, might be the mild, moderate as well. I mean, I don't know. Maybe there is one that just
the PCBH is 1 to 4 visits. These are all interrelated, but they're slightly
different. I think the first one that my mind wants to go to, probably the one about it being brief therapy.
Okay.
Yeah, because I think that's a big one that always gets, we even had a comment recently on our PCP satisfaction survey from one of our medical providers saying they would give higher scores if there was more relationship-based, kind of what they were saying. It seemed like they indicated more long-term.
Long-term, longitudinal.
Yeah. And the irony about it, as we've talked about in many other PCBH corners, is that there's a reason why primary care is first within PCBH, is that we are supposed to be about primary care. One of the 4 C's of primary care is continuity, longitudinal relationships, these things that are going to be relationship-based throughout someone's lifetime. So, and this is the thing that I know we always say now in our trainings, if someone is sitting into the audience and they're a BHC or a behavioral health provider, and their goal is to develop long-term intimate relationships with the community. It's like PCBH is probably the best place to do that.
Yeah.
We don't talk about it that way, though. We very much talk about it, and there's a reason, probably, because our care is probably more episodic.
Yep.
It is probably more like when things come up, you come in, you see us, might be for a couple visits on average. There's never that intention, though, to do that. It just is what usually just comes out from natural human behavior. It's long term, though. It's relationship. Just yesterday, sorry for going off on this tangent because I want to know where your mind going. Just yesterday, I had a patient that I probably hadn't seen for 2 years. Had come in and was coming in again for high blood pressure and for anxiety and asked to see me. And I was so excited. This is the thing that really gets, like, it makes me really love PCBH. Like, when I saw the patient's name, I was like, I haven't seen them in so long. Yeah. So going in and like we gave each other a hug, and he was definitely an individual as well that would never go into, he's a truck driver, he would never go into a traditional mental health office. It was just a really cool bonding moment of a visit, and it was longitudinal. It was relationship based without question. So I think that's one of the bigger myths and misconceptions is that PCBH, again, it's...
Yeah, we've had some organizations reach out, so I hope that you're watching, about some of those myths of PCBH from the physician side of things. And that's what kind of kills me when it's like, so there's so much stuff to learn, right? And with all the love, grace, and compassion for everybody, but sometimes it gets misconstrued that if a medical provider refers us to somebody once, right, and we see them, most commonly, based on human behavior, whether or not we were in private practice, whether or not we were at a community mental health agency, wherever we were, the number of visits for psychotherapy is 1.
And it's always been 1.
And so sometimes we've found that when patients say, I don't really want to follow up, or hey, maybe they say they want to follow up, and then they end up not coming back for that second visit. And so then the physician can erroneously assume, well, you guys are not really doing long-term work because we don't have, that huge follow-up. Like, we're primary care. If somebody doesn't show up, it's kind of, well, okay, well, there's another patient there. And it's like, it is dictated upon the patient. Whereas if you enroll into therapy, there might be a situation where somebody's monitoring that, they're reaching out and being like, oh, again, not saying that if you're in primary care that you can't have a registry, that you can't have folks reach out. There's lots of agencies that have some type of system in that. I'm just saying that's not the main system in place. And so there are some folks in primary care, because of the chaotic pace, that get lost to follow-up. But that does not mean that we're not valuing relationship-based. And my whole thing is like, and again, this is all the love, grace, and compassion to our physician colleagues, medical colleagues. I love them dearly. But we can't make somebody do BHC visits.
Nor.
So if they choose to come to one, like that's...
Nor, and this research is pretty much, like, it's really interesting research as well, and I think back to the substance use research, that, they did some studies about trying to match up, depending on what the perceived severity was of that individual, to the intensity of treatment. Okay. So if someone has, like, maybe a dependence is high, using regularly, that's going to be matched up with maybe, and potentially, dependent on the substance that they're using, might be inpatient. Okay. So they did a study where they tried to match people up, and what they found is what you would almost expect them to find. Sometimes it worked, sometimes it wasn't. And I think that's the other thing for us to, both as BHCs and PCPs, there is our mind's expectation of like what this human needs. Oh. And we don't know what they need.
Well, that's a huge topic.
That's a big thing, and I think that plays into this kind of misperception as well, as about like if PCBH is only, as you're saying, only seen someone like once, and then they don't come back. It's like a lot of times what comes up, I think, for BHCs and providers, like, well, they need more. It's like maybe they do. We don't know that.
First of all, we don't know that. Second of all, we're not in control of that.
Amen. And that's another reason why, this isn't about talking about what we love about PCBH. And it is something that I think really is something I love about PCBH, is it allows patients really to have the autonomy about when to come back. Because we're always available. Like, you can come back, and I tell patients all the time, I just told this to someone that we had been seeing episodic care. they've been doing well. We're moving to like, hey, 3 months, we'll check back in. And I told them, it's like, if something though comes up prior to that, come in.
Yeah.
We'll see you.
I had literally the same situation yesterday. Yeah, so it gets into this thing where it's like that the only type of care for when people really need it is that you're hounding them and like begging them to come in and setting multiple visits. And I don't know, I'm just, whether I was in primary care or not, I'm just really not, to be honest, that interested in that.
I agree.
I'm interested in giving care on the autonomy of the individual, which then brings us into another issue is the one that sticks out to me that just like makes me cringe, like cringeworthy.
I'm really excited right now.
Cringeworthy is that PCBH is only 1 to 4 visits, and you cap at 4, and then you refer. I mean, I actually don't even know which one's worse. The 1 to 4, the 1 to 4 visits or triage and refer. Like, I can't think of a job, a career, a calling that would be like less meaningful than to just like meet folks, maybe help them. I mean, I would hope them, but help them. But like think that, oh, I can't help them. So I have to, like, when my entire job is to get them to somebody else to help when most people are asking for help. Now I'm not saying, now we're going to have to do the whole caveat. I am not saying that folks, if they want to go to especially mental health, that I would ever be a barrier to that. I'm just saying, when I meet somebody, regardless of the severity, which gets back to the mild to moderate only, no matter the severity, I show up fully and completely ready to help. And if that goes to another visit, then so be it. If that goes to 15 visits, then so be it. If there was a situation where we had 15 visits and the patient said that this was not helpful for them, then I would absolutely try to figure out a way. But as long as we're making progress and the patient is telling me, this is what is helpful to me, this is what's allowing me to get back on track, I don't know. It doesn't match with primary care.
You're operating, the thing I love is that you're operating like a primary care provider, not as you said, like if there's ever a stance, like what a primary care provider does, we always use this example like with diabetes, that if a patient is meeting with a primary care provider and the diabetes just isn't getting better and they're requesting maybe a higher level, that PCP will absolutely make that referral to an endocrinologist. And they're not going to do that just from the beginning. They're gonna work with it and see what's going on. The other thing that what you were saying and my mind was just loving so much, when you break down what relational frames then correspond with that first visit, when you have 2 different options. One option is triage and refer. The other option is like, let's get something done. When you think about just how both the BHC and then the patient also responds to that, these are vastly different relational frames. So if you're in let's go with the latter one. Let's go with the one if you walk in, as you were saying, it's like, hey, walk in and just try to get something done. Have a moment with a patient. Regardless of severity, I'm going to just try to help you today. That is super meaningful as a BHC. Super, like, my job is to help this human that's here right now.
Know them, learn their situation, learn their context, share that with the medical team.
And that's my intention going into the room.
Right.
Is that I am going to help this human that's there. Think about the patient's response to that. There's a human coming in right now that is literally trying to help me in the moment.
Who's part of my regular medical team. Whether or not you see them again or not, just knowing that you could see them again, I think is deeply meaningful.
And think about if the patient came in and maybe they had like this handoff that I had yesterday for another patient, had significant trauma. And you can even see within their minds how much they've been told and built up. I'm not someone that can be helped. I'm someone that is broken. Think about then the patient's response, where it's like, this person is saying they can help me right now.
So walk me through that former situation then.
So the former one, BHC goes in, it's like, my job is to assess severity and then refer out. It immediately changes the nature of that initial visit. That no longer is it about the human, it is about symptoms, it is about pathology, and it's about this arbitrary algorithm about who stays and who goes.
And talk me through if you're a patient, you agree to meet with a behavioral health provider, or a licensed professional.
Maybe reluctantly, maybe because they're concerned.
Begrudgingly.
Maybe the PCP did a really, really good job. And then let's talk about the PCP's response to both those situations too. Did a really good job selling the visit.
Yeah. So then BHC comes in. Turns out the person is having more severe
something that whatever arbitrarily
that
we said isn't appropriate for PCBH.
And we refer them out.
To a system, and again, grace, love, and compassion, it's probably going to take a little while to get them into treatment to begin with. Let's look at each one of those three individuals that are involved in this right now. The BHC, the patient, and the PCP. For the BHC, what would you say is the relational frame that they have with that visit? How do they feel?
I think it would be a little bit mechanical, a little bit algorithmic. It's kind of like you're assessing the severity of the symptoms, and then you're thinking of all the ways in which you can maybe have somebody else help them. So the ownership is low, I would say, like of you and them. It's kind of like, okay, let's see how we can get you elsewhere.
My mind wonders, like, how is it fulfilling?
Well, I couldn't imagine that to be. I know we're saying a lot of things right now.
Like, is it
all the love, grace, and compassion?
Like, is it rewarding?
I would not find that to be rewarding. I mean, I want to.
It's almost like we're putting up a wall immediately.
There's a distance.
There's a distance immediately. If you're the patient.
You know what I always think with that is like, and I'm going to swear, which normally I don't swear.
If you're around us in real life, you know how much we swear. We just
in real life, not normally on these PCBH corners. But if I was already feeling like I had mental health problems, or people have told me that, or I got a lot of trauma, and I'm kind of feeling like, man, I'm fucked up. And somebody who is a licensed psychologist, licensed clinical social worker, somebody who is licensed in front of their name, and they're like a bona fide mental health, behavioral health provider. They come in and they tell me, like, yeah, I mean, based on your symptoms, like we can do a little bit today, but like based on your symptoms, I would really recommend a higher level of care. I'd be thinking, man, I really am that fucked up.
Damn
like
right.
This person who has, especially for the psychologists out there, if you have doctor in front, like even this doctor can't help me. They got to send me elsewhere.
And think about if the patient was reluctant.
Oh,
and it's immediately reinforce the thing. It's like, man, I'm never bringing this up again. Like, I didn't even want to meet with this person. And now this person is saying, I got to go somewhere else. Think about the PCP.
Yeah.
Because the PCP, if I'm that PCP and I've worked to get this patient in to see the BHC, and now the BHC is saying, hey, they're too complex for me.
I'll do some deep breathing, but we'll get them to somebody else who can really help
There's
them.
a part of me that is just like, the PCP would just be like, I'm not going to use this again.
Yeah.
Like, what benefit is this getting?
Well, because the BCP could do that.
Correct.
A BCP.
They already did that. It literally did that by saying, this person needs some help. So I think that's where, when you think about just the ripple effect of that myth, which goes into, like, as you said, the 1-to-4 visit structure. And I think we should, as we talked about in previous, PCBH corners, the reason why 1-to-4 visits has made its way into the literature is that is most likely the common scenario. When you look at data, when you look at just, and this isn't just for PCBH, this is largely related to especially mental health. It is going to be like 1-to-4 visits, most likely. There was never, though, an intention of saying there's caps.
It was descriptive.
Correct.
Not prescriptive.
It's amazing about when things do get applied, like when they weren't meant to be applied that way.
They were describing that as 1-to-4 visits, and then became prescriptive that this is what we're going to do. And those are two very different things.
And they were also trying to very much, the founders were very much trying to say, like, you have to be intentional about your visits, because you can't have people just continuing to follow up and up, because you're going to run into the same access kind of problem.
Which PCBH is largely engineered to help address the access problem. And if you have every single person coming in once a week, then absolutely you'll run into that.
So I think that's a big thing we just need to call attention to, that that's a misconception of just like, what does that 1-to-4 visits mean? 1-to-4
is descriptive, not prescriptive.
So we've talked about the 1-to-4 relationship. We talked about mild to moderate concerns, about how that doesn't. The one thing that I wrote down actually first, and I was surprised my mind actually went to this first, is about PCBH doesn't have any research to support. And the thing that's, and again, it's, one, I would.
Oh man, that's a whole other.
The thing I'll try to be quick about
Okay.
this. I'll try to be quick about this. I think the problem is that one, there's almost like two things. One, there is research that's growing about PCBH. The problem is though, I don't even like saying that because PCBH is not an intervention.
Correct.
It is a philosophy of care of how you're delivering it.
And primary care has more research than any other medical system that exists.
And the thing that actually should be more kind of research is just, and the research about this is growing and pretty, I would say, robust actually, is what can people do in more efficient or intentional visits, like single session therapy has a really good research. Like that recent study that just came out about PTSD treatment in 4 visits that they had really good results. Whenever someone says PCBH doesn't have any research, my mind's like, again, you're not understanding what PCBH is. As you said very well, it's like it's part of primary care.
And primary care
has an abundance of research.
So if we help support primary care and execute it better.
That's the thing that just is difficult. That it's like, I was just actually talking to someone the other day that they were actually describing some difficulties because they know some journal reviewers, like as soon as they see something PCBH, it's just like, there's no research to it. There's no research to it. And it's like, again, that's such a misconception about what PCBH is.
Now you said that there's 2 things. There was something else you were thinking.
Well, I was saying 2 things within that domain. One is like, there actually is research for PCBH. The other one is like, that actually is that's not even a good statement to say anyway, because that's not what we're trying to essentially research.
And when you're saying is like, when PCBH does or doesn't have research, most of the time people are talking about, can you make a meaningful impact with patients in like 4 or less visits in 30-minute segments? That's what people are referring to, but really when it looks, we have a lot of literature.
I know, that's the thing. We actually do.
You can, like you said, single session therapy is tons and tons of literature. There's tons of literature that show that we can help people in 1 to 4 visits. Again, that's descriptive, not prescriptive. Get better.
Nice.
But in general, primary care as a whole has so much literature that it helps. And it's the only, it has, for every dollar put into it, Robert Graham Center has done so much on that.
Oh my gosh.
For every dollar put into primary care, you're having population-based changes versus every dollar that's put into specialty care.
And you know what's interesting my mind just goes to about this is like, and we've talked about this, it's like, what do you research within a PCBH system? Do you research like, do the people that see BHCs get better than the patients that don't? I think that's a terrible thing to research because I would hope every patient, regardless if we see them, that's a primary care intervention.
But don't get me started on this because I think that you should be looking at patient engagement. I think you should be looking at
what is the outcome measures
big
that we're using?
metrics across the whole system. Okay.
Yeah.
I want to get back to, because that's a whole PCBH corner in and of itself. About misconception, myths, and it's one that we've been kind of dancing around a little bit, but I'm not sure if we've talked about it explicitly, is that if you're a BHC working within primary care, that you are not relationally based or relationally connected. And we did do a PCBH corner on this. I think it was back in like
we've done a couple of
2018.
Yeah, it was in I think the small classroom over there.
Yeah, maybe. Yeah.
Because we did one, I think, at the hotel the one time that you talked about, and then we did another one, I think, in the small class. We've done a.
They're kind of cute to go back and watch. I think that we're a little bit more eloquent on the topic now than what we were. But that's another one that's like that cringes me to my soul, and for many reasons. Because it's like if you're getting into PCBH so that you don't have to deal with people, or like have like. Deep connections are like, I don't want to have to deal with people. So I'm just like going to come in and be a walking deep breathing handout or something. Like, I don't know. That's like not very inspiring at all. And then if it's like the opposite of like, that somehow being relationship based is somehow less scientific, less.
You get hit from both sides of it, right? Like it really is interesting.
From all the sides. I'm not even making sense with what that's how much it messes my brain up because it's like, it's always about people. It's always about people.
I remember you always talked about, who was your pediatrician growing up, or your family doc?
Dr. Agnew.
Yeah, mine was Dr. Swan. And what was really interesting about it, I wouldn't go see Dr. Swan a lot. It'd be, whenever something came up, or the, wild child visits and stuff like that. What was so interesting, the relationship that I had with Dr. Swan, was profound. I always think back about Dr. Swan and how I felt going into those visits, and just how the office was. And it's amazing to think about when you view and you step back